So I've been working in sustainable development for about 20 years. It seems a very long time, but I think some of those points that were made earlier around the evolution of, so the carbon accounting piece back from 20 years ago, where the low carbon agenda, sustainable development agenda was sort of a movement, all the way through the point to an improving, more regularized process for accounting for carbon emissions, getting to a point where we are now, where the low carbon economy makes up £43 billion odd of the UK economy and employs 400,000 people. I've seen that sort of change from something that, like social value, where it starts to where it can get to over the last few years. And it's been an exciting journey, with a lot of opportunities along the way. I think obviously, the question that was raised earlier about what is the problem that we're trying to address, I think is a really important one. And if you ask that of health, in terms of the social value or the sustainable development space, it's about health outcomes. At the end of the day, that's our currency. It's about, what can we leverage in terms of health outcomes or prevention. And actually, the most efficient healthcare system is the one where people don't get sick in the first place. So actually, delivering a system where we ensure that we're focused on prevention is absolutely critical. However, if we look at the way the NHS has worked around the social value space, I would definitely say, with some certainty, that we haven't nailed it yet, in terms of how social value fits within that piece. So, and I've heard that echoed across the room in a number of different presentations today. But arguably, of all public bodies, the NHS and the health and care system has most to give, and also has most to gain from. I'm on the first slide at the moment, so there you go. I'm on that one. Thank you. So the most to give and the most to gain in terms of our approach to social value and sustainable development. There was an interesting piece of work done, I think, last year by National Voices that looked at how much coverage social value had within clinical commissioning groups and within emerging sustainability and transformation plans. And they calculated that around 13% of CCGs had a social value policy, and around, similarly, 13% of STPs mentioned social value or had some coverage of social value in their planning for the way in which the health system will be structured going forwards. And I think that broadly reflects our analysis as well, looking at the same sort of information we've come up with, or from a different angle, we've come up with broadly the same picture. But I don't think that message necessarily gives a fair picture of the breadth or the work that's gone on around social value and social impact within the NHS over the last decade or 2 decades. If we look at social value as a term, I think broadly, it's fairly interchangeable with sustainable development, as we've heard a few times today, or wider determinants of health. It depends on what angle you come at them. Sustainable development tends to be lumped with estates teams, and social value gets lumped with procurement teams, and wider determinants of health gets thrown at public health teams. But actually, at the end of the day, all of these are looking at the same sort of problems, just from different directions. So, if we look at what we've been doing around sustainable development first, and where we've got to build on from that sort of picture, I think we actually start to see where the opportunities might well lie within the health and care system. So, I think if we sort of crystallise it into a sentence, really, the NHS is about 10% of GDP. It's a huge entity, a huge part of our society. And actually, if we're looking at the way in which we deliver health and care services, actually, it's the way we deliver health and care services and social care services that should be also improving the population's health. We shouldn't just be looking at what we buy. We shouldn't just be looking at the fact we deliver health and care. We should be looking at the way in which we deliver health and care. And I think that's where social value and sustainable development sit really within the sort of the value at stake, as it were, here. And obviously that first do no harm really should be integrated. It is integrated, strangely, as a part of the core mentality of the health and care system. But actually not just doing no harm, but looking at where we can leverage benefit to actually ensure there's prevention embedded. So that, if we look at why we do this, that's sort of our core currency. I think it was mentioned earlier, maybe sort of playing devil's advocate, in a cash-constrained environment, when there's increasing constraints on budget, maybe we should be just getting on with healthcare and not worrying about the rest of the problems of the world. That's sometimes the echo that you get back from the system. There's so much to do. How can we do this other stuff? And I think that is the challenge. It's not. The point is, this isn't other stuff. This is core business to health and care. And I think getting that point across over the last few years has become easier and easier, but it has been an incremental journey to say, actually, it is possible to do harm while doing good, and we need to actually make sure we're not doing that. So, and as I say, the two currencies really in terms of the NHS are obviously health, but also the cost of delivering high-quality healthcare. And that focus, which I'll come on to in a bit more detail in a second, around sustainable development in the first instance, it's already been proven to make significant financial savings, cashable savings, and have health value for the health and care system. So since 2007 alone, we've saved about £2 billion for the health and care system through a focus on sustainable development. A lot of that's through resource efficiency, energy, waste, water, those sorts of things. But also, at the same time, that money's been obviously funneled back into healthcare, which has allowed us to deliver more healthcare, and has resulted in reductions in things like air pollution. It's resulted in reductions in things like burning coal within health facilities over that sort of same time period, and cut about 3.6 million tonnes off the UK's carbon footprint, of the NHS's carbon footprint. So, those co-benefits of action have been very well demonstrated through the approach that's been taken on sustainable development. So you'll have to forgive me for bunging these up again, probably for a third or fourth time today. But to take a health stand on the SDGs, if you take any one of these 17 SDGs to their greatest extent, if you don't do them, it results in poor health. If you do them, it results in better health. So these are global goals for health. And I think, if you look across the list, they're not all environmental, because sometimes people look at sustainable development and say that's an environmental issue. These are broadly economic, social, and environmental, the whole triple bottom line approach, which is, of course, a core part of the work we've been pursuing over the last few years, which is why I'm head of unit for the Sustainable Development Unit. Now, I'd say in terms of social value, that actually it sits as a reflection, almost a local reflection to the SDGs. They cover the same sort of ground, but actually we're looking at a sort of local reflection of this. They're locally applied sustainable development, as it were. That's the way I tend to view them, applied sustainable development. But we do have a valuable framework, which does have a set of metrics associated with it. So making sure we establish those strong links and that cross-referencing between those two approaches, I think is absolutely critical. Otherwise, we lose that global legal framework or global agreement framework that sits behind and gives weight to this process, as well as the UK legislative framework that we have through the Social Value Act. So using health terminology, if we're going to look at, I'll skip through it. If we're going to look at, I'm missing one piece off the bottom, I'm afraid. The social and economic and environmental piece, the triple bottom line, as it is sometimes called, I would say those are three life support systems that sit behind the wider determinants of health, the requirements that we have to meet to actually ensure we have a healthy population. If we don't look after environment, that causes negative health through things like air pollution, water pollution, soil pollution. Likewise, society and economic issues. If we don't actually maintain a vibrant society and a thriving economy, those have negative impacts on health. And actually, those are hardwired into the NHS constitution. The NHS is committed to providing the most effective, fair and sustainable use of finite resources, not just energy, waste and water, but finite resources in their broadest sense. And likewise, high quality health and care for now and future generations is the NHS England strapline. It's amazing how many times you ask, where does this come? And people don't recognise it as the NHS England strapline, even within NHS England. But I think it's a really important point to make, that this is hardwired into what a high-quality health and care system is. So the way we have worked over the last few years is actually to try and make sure that this sort of mentality is embedded into what is perceived as high-quality, well-led, efficient health and care. This isn't an add-on. As was mentioned earlier, this is about good health care and health and care practice. Starting with putting our own house in order, You're looking at resource efficiency, carbon, waste and water, but then considering our impacts through staff and communities, and then considering our impacts through supply chain as well. And getting things like this embedded into what is actually understood as high quality health and care is not straightforward. It's been a long slog, and this is why I say I'm not 100% convinced we've got there yet, because there's an awful lot more to do. But the value, again, at stake, if we look at the sort of scale of influence there is across the health system, 1.4 million staff is 5% of the UK working population. That's £48 billion of the NHS spend each year goes through our staff directly into local economies, through the people who work within the NHS. We have the UK's largest commercial estate, 1/3 of all public sector greenhouse gas emissions. Those buildings are often based within the most deprived, most unwell communities. So if we want to unlock social value, focusing on putting green space in our estate, making sure our estate is accessible, hosting third sector organisations, we have a position in the most deprived and health deprived communities in the country. Likewise, 3 to 5% of all road traffic is health related in some way. So if we're looking at the issues of air pollution, we have influence over that sort of range of impact in terms of health. And then there's the £34 billion that we spend on products and services. And as was mentioned earlier, roughly, I don't know the exact figure, but roughly 80% of that might be tied up in frameworks, 20% of that locally influenceable, more or less, which means that there's about £6.8 billion in that context of influenceable spend. Now, these areas, if we look at traffic and we look at estates, they have potentially significant cash flow savings. Working with our staff has a potential to help retention, staff morale, reduce sickness and absence. And of course, if you're looking at where you would start around sustainable development and social value, starting on those areas which have direct cash flow savings, potentially influence your business, but also have a huge potential impact on health just because of the scale and the focused areas of activity, because all of our work is concentrated within the areas of highest ill health, that's where you'd start. The supply chain piece is absolutely critical because there's also a huge amount of value and potential to leverage local economic growth through engaging with our suppliers. But I'd say if you're looking at where we have most impact in terms of our footprint, I think you have to get the balance right between those different areas of footprint and those different areas of impact. So, the anchor organisations point, I think, is a really useful phrase. I think that point about, often the largest local employer, often the largest local spend, often the largest local estate, and often the largest local source of air pollution, or one of the largest local sources of air pollution. I say maybe not sources, health-related travel being a source of air pollution. As an anchor organisation, we have to be very mindful of the fact that we're in the health business, not just the healthcare business. So the Social Value Act has provided a good, I think, push in terms of how we do that through procurement, but I don't think it's provided enough of a push in terms of the weight that goes behind it. I think it's a useful guide, but I think that point around do we have the skills to act on it, I think is something that's constantly in the back of my mind. I think we do have a need to act, but actually it's not always obvious how we act. And actually thinking about the role of commissioners and providers, if you think about how we commission health and care, the provider fleet, as it were, within the health system, and their relationship with the commissioner organisations, that contracting relationship around how we work with our providers as the largest source of our impact and potentially largest source of our positive impact, and how that commissioning relationship, that contractual relationship works between the two, is probably where we have the biggest potential to influence, if we're thinking about the size of employment, the size of estate, and the size of impacts. Thankfully, the Social Value Act is starting to get embedded into the mandates that exist in the system. So the 5-year forward view next steps, this is the easy read version you can see from the bottom. It's a very light read. Or maybe not, it's quite a long read. But actually, there is a quotable point in there that says about the importance of considering the Social Value Act or using the Social Value Act as we develop our local health and care systems. Now, I've got to say that's a footnote. but it's a quotable footnote, so it's up on the screen. But nevertheless, it's starting to get embedded into the way in which we think about the system, because I think it's taken a long time for the health system to internalise that concept that actually we can do harm through the way in which we deliver healthcare, and actually we can get serious about prevention by delivering healthcare in a better way. Okay, I'm going to skip through to a couple of examples. So, but the main point on language is that actually we can get greater health gain for every health pound if we consider social value in the way in which we commission and the way in which we procure services. The key point is this is already happening. So we had a sustainable development strategy adopted back in 2014. It's embedded into the NHS standard contract. Every NHS provider has to have a sustainable development management plan and has to be mindful of the impacts of the social, or the application of the Social Value Act. Every provider and commissioner has to report annually on a wide range of metrics on how they're delivering in this. And those SD management plans have to cover corporate impacts, staff and community, and supply chain. So this is already embedded into the mandates in the system and the reporting in the system. But it's called sustainable development, it's not called social value. And I think we could get better, actually, at embedding the principles of social value through that matrix. Already we've got 71% of providers have a sustainable development management plan, 85% have sustainability reports, but it's not 100% yet. And we're working at the moment with NHS Improvement to make sure that's pushed through to the remaining provider organisations that aren't actually picking up on this for the economic, financial and social and environmental value that it represents. This slide and one more, and then I'll be done. So, SD management plans are required now, and this is as of the end of last year. This is the guidance we produced new of last year to cover a wide range of impacts, but also in each of those impacts they're required to consider, and how does this benefit patient well-being and us as an organisation? How can we work with our supply chain to yield these benefits, and how do we work with our staff and community to address these issues as well? So again, we're increasingly internalising this into the way in which the system works. And you may have seen last week that Simon Stevens at an event was quoted as saying that we are, at this point, looking at the health inequalities impacts of the way in which we deliver health and social care, or the NHS delivers healthcare. It was actually, he referenced a board paper that will be coming out in this month's NHS England board covering health inequalities and particularly employment, economic investment and pollution. So it's worth keeping an eye out for that. I'm going to skip past this one and just go to this one. I'll finish on this one. I have to apologise to Nottingham. I live in Nottingham, and Nottingham is a fantastic city. It's got 1 in 20 of the rooftops have got solar panels on, the largest biogas bus fleet, all sorts of other accolades. But at the same time, it has, if you look at the recent Marmot figures, one of the worst life expectancies in the country. It's one of the first 5 clean air zones, and the hospital, as I say, is surrounded by an area of low-income housing. In this case, mortality from air pollution is estimated to be around 6.4%. The hospital alone, health-related travel from the hospital alone, makes up 78 million miles of road traffic a year. We produced a tool called the Health Outcomes of Travel tool from the Sustainable Development Unit last year, which estimates every single health organisation in the country, the miles that they travel, the health impacts of that, and the economic impacts of that. So that tool now allows each of those health organisations to say, from our transport footprint, that leads to X number of QALYs impact in our local community. And in this case, just the acute trusts are responsible, well, the travel related to the acute trusts is responsible to 4% of all of the QALYs lost from air pollution, at an local economic cost of 3.3 million. So in terms of translating what is a local impact into health language and economic language, in this case, every single trust in the country now should be able to see that, but also see that in terms of the fact that they can use the tool with their suppliers to calculate, if they know the miles related to providing that service and the miles related to providing a different service, what the differential will be in terms of economic impacts and quality cost. The same with commissioners commissioning services. they should be able to look at two services if they can quantify the miles resulting from delivering those services, what the differential impact is. So in that case, we're allowing social value, in this case from air pollution, to be quantified and calculated and valued and tracked within the delivery of a program or design of services. So feel free to download that tool. It's very useful. It was actually used by the Chief Medical Officer to produce the Chief Medical Officer's report this year, which actually focuses on pollution. This one you may have seen before. I'll skip past it. I think I'm over time, but yeah. I've got to say it very quickly. I'll leave you with a slide with something of the Social Value Portal, because this is an amazing example of what could have been a capital procurement. They decided to look at it as a service procurement instead, apply the principles of the Social Value Act. Instead of just going out and buying solar panels and sticking them all over the roof, they thought, well, actually, we could go out and raise investment from our local community through a local community energy company. They raised £336,000. That's returning 4.5% return on investment to all the local investors, £100 to £1,000 odd per investor. That's a community-owned asset on the roof, returning investment and money back to the local community, saving the hospitals energy costs, it's reducing carbon emissions, and £300,000 of the revenue that they make out of the solar panels each year funds a local fuel poverty programme. That hits all of those sustainable development goals. That, for me, is a perfect example of social value commissioning. It wasn't a service contract, but they redesigned it as a service contract to maximise the social value available. So I'm going to leave you with that because we're working currently with Social Value Portal about how we get this as a more consistent approach in terms of embedding the sorts of outcomes that we can see that are possible into the way in which services are designed and services commissioned. Thank you.
Thank you very much, Jerome.